Hello everybody, my name is Linda Kelly and I'm the International Clinical Nurse Advisor for Vigon. On behalf of Vigon, I'd like to welcome you all to this webinar, which is entitled Vascular Access in a Post-COVID-19 World. We're delighted to announce that almost 650 people have registered for the webinar from all over the globe, including India, the Ukraine, Saudi Arabia, Portugal, US and the UK, Mexico, Lebanon and Philippines, just to name just a few, to extend a really warm welcome to you all. The aims of this webinar are to discuss how vascular access units have managed during the global pandemic, what lessons we've learned, and how things have been managed during the pandemic. We want to know what practices improvements could be made and what changes could be introduced post-pandemic. We encourage you all to be involved in the discussion that will take place following 3 great presentations. To do this, please use the chat button just on the right-hand side of your screen. We'll aim to answer as many questions as possible, so we'll put these to the speakers. Any questions that we don't get to will be collated and answered post-webinar and shared with all of the people that attend. Before we start, I'm going to hand you over to Luke, who's going to introduce the speakers.
Okay, thank you, Linda. Yes, it's a pleasure to share our knowledge and to share this webinar with Matt and Mauro. So first of all, let me present my 2 colleagues. And first of all, Dr. Matt Simpson, which is a consultant anesthetic in St. James University Hospital in Leeds, in UK, which is one of Europe's largest teaching hospitals. It's in the Leeds Center for the care of acute medical patients and older people as well, and housing all of general surgery and the Leeds Cancer Center. So Matt heads up a team of 5 consultants, 6 anesthetic assistants, and the dedicated life coordinators, as well as providing teaching, training, and advice for over 30 advanced nurse practitioners across all the specialties within the trust. They have 4 dedicated third session per week for Ekman lines, Portacats, apheresis line, VASCATs, and 5-day words-based service on Medlines, PIC, and as well a dedicated PIC rooms for hematology patients. So, as well as vascular access is an anesthetic leads for obstetric anesthesia and also works in colorectal, ophthalmic, and thoracic surgery, as in an innovation champion for the trust. And so maybe let's go for the first lecture with Matt, and after I will present Mauro and myself. So we give you the time now, Matthew, for 15 minutes for your presentation, if you like.
Perfect, thank you. Thank you, Luke.
Thank you very much.
Very nice to be here. Thank you for inviting me. I will just share my screen. There we go. So hopefully you can all see that. So I've been asked to talk about peripheral lines for COVID patients that didn't require intensive care. And I thought I'd start off really by just giving a very brief overview of the service we have and then how that changed during COVID. A little bit about how we assess patients, so which kind of line we kind of feel is the most appropriate for them, and then finish off with some lessons that we learned during the COVID crisis. So, as Luke said, we're quite a busy vascular access unit. At the minute, we're up to about 5,000 lines a year. And we're broadly split into 2 major types of line service that we have. We have an oncology hematology service, and that's been running for many years now, run by myself and my colleague, Dr. McClure. We both do a theatre list a week, putting ports in, Hickman lines, apheresis, VASCAS, and the difficult PICs that either people have failed on or they've got altered anatomy. So we have access to fluoroscopy within the theatre. And we also have a 5-day-a-week PIC room, which is run by 2 advanced nurse practitioners. And then around about 2005, 2006, we set up an acute line service run by, again, myself and my colleague, Dr. Chandra. And over the years, we trained up 6 anaesthetic associates, which are absolutely crucial. And we have a line coordinator, which is fundamental to the success of our line service. Just as an aside, if anyone is thinking of starting a line service up or wants to progress it, I can wholeheartedly recommend having somebody that is non-clinical and is solely there as a coordinator to organise the lists, organise the patients, take the phone calls, and just basically be that port of call for advice for the wards. It has been crucial to the success of our line service. And we're now at a place where we have 2 theatre lists a week on a Wednesday and a Friday for ports, Hickman lines, and again, the difficult picks. And we were getting a ward-based service, which was originally officially 1 day a week for picks and midlines. And then Leeds has several different hospitals, and one of the other hospitals, we also have a list run by an anaesthetist and a ward-based service over there. This just shows you really what's happened in the progression of our lines for that acute line service. And it was one of those things where basically if you build it, they will come. And we provided the supply, and all of a sudden the demand has just gone up to the point where we are now, where above 5,000 lines. And partly that's due to the fact what we have is we created an electronic booking system for our lines. Here's a picture here where you can see we have orders awaiting verification, and they're all color coded in terms of the urgency of the line, red being within 24 hours, amber being within 72 hours, and green within kind of 2 weeks. And then what that happens is our lines coordinator looks at all those requests and then kind of accepts them down here. As you can see, these are all the accepted orders that are waiting at the minute for us to put in. They then get allocated to different areas around the hospital because we have access to the theatre list in oncology, the theatre list in acutes, and we have the pick room and the ward-based service. So all of that is kind of done by our lines coordinator. And what that's allowed us to do, we also have, alongside that, we have run this electronic line record. So all our lines are recorded electronically. We are completely paperless. And as you can see, I won't go through all of this, but basically we record where we put the lines in, the indication for the line, the types of line, and any difficulties and complications, so that the patients that require multiple lines, we can look back and see what happened last time. And what this has allowed us to do with this vast amount of data over the years is we're now touching on a point where we can get something that looks like this, which is our dashboard. And we can see the specialties that are ordering them. We can work out basically the costs, the length of stay that these patients are having. We're only just starting to touch the base with this kind of dashboard and look back at our data. And that's going to hopefully enable us to kind of do things a bit better in the future. As you can see, I won't go through all that slide, but essentially our top 5 specialties that are ordering lines, this was before COVID, was oncology, hematology, gastro, infectious diseases, hepatobiliary, and then general medicine. And this was the main indication for lines, again, pre-COVID. So about 1/3 for chemotherapy, again, about 1/3 for antibiotics, and the rest was a mixture of TPN, difficult access, vasoactive drugs, and others. Then, as has happened to us all over the world, the COVID virus has struck. And here, because our line service is mostly run by the anaesthetic department, anaesthetists and the anaesthetic associates, all of us got completely redeployed to cover the intensive care units. So all the theatres also got converted to mini intensive care units to cope with the surge in intensive care patients that we had. Clearly, we had no operating space, so all elective surgery was cancelled, and many of the patients were shielding. So we had to, as a vascular access service, we had to make some serious adaptations. In terms of the 2 services that we have, the oncology hematology service, we kept that running, but it was mostly filled with just removals and urgent requests only, because none of the actual cancer treatment was happening throughout COVID. And then the acute line service, because we lost all our theatre space, we decided to move to a 7-day-a-week ward-based service, which was essentially run by the anaesthetic associates from all that time. These are some interesting graphs from our data that I pulled up. So we've got on the left the pre-COVID in blue, and then on the right was the last kind of months that we're doing now. And as you can see beforehand, it wasn't too much of a difference between theatres ward and the dedicated lines room, but during COVID, the vast majority of our lines were put in on the ward. We still had a few in theatre and dedicated lines room, but again, we moved to that completely ward-based service. In terms of the lines that we found we were putting in, again, on the left is pre-COVID, we were putting about 325 lines in a month. And most of those were kind of picks, midlines, vascas across there. But as you can see very clearly there, we have gone to almost universally a huge surge in the midlines that we're putting in. Yes, we're still doing PICC lines and still doing the others, but you can see that huge spike in the midlines that moved up. The indication changed rapidly as well. As you can see, chemotherapy dropped from about 1/3 down to 16%. And the biggest jump by far was that for difficult vascular access and for fluids and medications. That jumped from 8% up to 36%, which was probably unsurprising. In terms of getting the right line at the right time, I like to say actually it's a bit more than that. It's the right line, the right patient, the right time, the right site, the right vessel, the right care, the right duration, right documentation, and the right training. It's about getting absolutely everything right at all times. And if you can do that, then you can actually make some success with these patients. What we actually found during the COVID crisis was that 26% of our PICC requests ended up having a midline. And this is likely due to lack of knowledge on the wards from various surgical specialties and medical specialties just requesting a PICC and actually not having the knowledge of what a midline is capable of doing. So again, having that lines coordinator to look at those requests, having that indication of what this line is for, and then us being able to change that to the most appropriate line for that patient. And I'll touch about why we feel the midlines are a bit more appropriate in the PICC lines in a minute or two. Speaking about assessing patients, this is kind of what we use. It's a pretty standard stepwise approach of selecting the line. And again, basically, we need to discuss that vascular access history. For us, it's relatively easy because we can look back at our historical records. We can just bring up all their line history and we can see what sites we've used. We can see any complications we've had in the past. Looking about what their current access is and what their actual diagnosis is and what do they need. Clearly, there's other things to avoid, like history of breast surgery. If they've had axillary clearance, you might want to avoid that side. Are there anticoagulants? Where are the fistulas? And one of the big ones for us is making sure there's available nursing or medical skills that are capable to maintain that device competently. We actually have a PICC pathway which we give to the wards, again for the midlines as well, which helps them to look after those lines. But our biggest problem by far is just the skill mix of the nurses that look after the lines afterwards. And then lastly, obviously, you've got the vessel size and catheter size following that. And touching on that, I might be teaching this to some of you already know, but basically what we kind of say is clearly you've got your vessel wall and you've got your catheter that's sat inside there. We know that if you take up more than 1/3 of that kind of cross-sectional area, then you increase that thrombotic risk. So French gauge catheters are essentially diameter times by 3. And you've all probably no doubt seen this table in some form or another, where essentially if you have a vessel diameter of 3 millimeters here, and you put a size 3 French catheter in, then you're only taking up 11% of that area. So essentially the rule of thumb tends to be you want to put in the French size into the same size vein. And if you do that, you end up with only keeping that 11% there. And that's something that we kind of do more or less, and we advocate through our sessions here. Going back to this, again, adding to this with kind of the COVID things, other considerations that we took in place that I think is really important was a need for a CT scan. CT scans was one of the diagnostic tests of value for COVID, looking at the lungs. And if we thought there was a need for CT scan, we would not just put a standard midline in, we put a CT rated midline or a CT rated PICC line in, thinking outside the box, thinking forwards about what might be needed for these patients. Again, a lot of these patients needed repeated blood sampling, and that's why midlines come into the foray, because you can take samples from them. It's relatively easy. It saves more stabs for these patients. And we want something that's potentially got a long dwell time. And again, that's where midlines come into their foray as well. Other considerations are protecting the inserter. Clearly, we've got to wear PPE, and you want something that takes minimal exposure and minimal kit going into the room, so to avoid that contamination going in there. And this was something that we've actually been quite familiar with for a long time. I look back and I took this picture. This was in 2015. We have quite a big infectious diseases ward, and this was going into a room with multi-resistant TB. So we were quite used to putting lines in wearing PPE, and there's not much difference there from that to June 2020. So in terms of new skills that we had to learn to do this, all my team are very capable of putting these in on the infectious disease ward. So it was relatively simple for them to do that. It was just something that they've been very used to. We've also got to ensure the effectiveness of that line, and we want a line that we think is going to last for that duration, and something that is kind of not going to cause relatively those complications that we see. And as a team, we felt the most appropriate one for there that ticks richly all of those boxes is a midline. It's something that we use a lot of, as you can see from those numbers before, and we're quite confident that it did very well for us in this time here. A little bit about how we go about it. This is what we were doing. This is we have a trolley with all the kit in the drawers, and we kind of take this trolley to the wards. It has an ultrasound on it, which is no keyboard there. It's very easy to wipe down. Ideally, we'd like to get a mobile, a wireless ultrasound scanner, but we don't have one yet. Hopefully we'll be getting one soon. But ultimately, that would be the best thing to use, because it's all wiped down, it's free, there's less wires. We want to avoid taking as much stuff as possible into that room. So everything was done with an insertion pack, and the midline and everything is in there. And time-wise, it's very, very quick to put a midline in. You're talking less than 5 minutes in most cases. So your exposure in that room is very limited. And you're also enabling the wards to able to go in and take bloods very, very quick, again, minimizing that exposure time to the patients. So essentially, just to summarize what we found as rather a large unit of vascular access, we found that moving to that ward-based was absolutely fantastic. Again, we were used to that ward-based thing, so it wasn't a big change for us. It was something that we were just enhancing. And what it also meant, we weren't having to move patients around the hospital. We weren't moving infected patients from one ward down to theatre or moving them down to the PIC room. We were going to them and using their rooms as that kind of hot zone to go in to do there. We also found that our electronic booking and recording has been utterly superb, just having no paperwork where you're not writing things in the room and then having to take them out of the room. And also allows the doctors to just order the lines on the ward, and then we can pick that up remotely and just prioritize things and prioritize the patients to go and get things done. In terms of positioning and technique, again, having already had that ward-based service, my team was already very skilled with adapting to these patients. So we were putting them in the room. A lot of the patients were on CPAP in the CPAP HUDs, and so clearly we can't lay them flat. We didn't actually manage to do one prone. There was a couple of patients that were kind of voluntarily proning themselves, but we found actually we just kind of put the lines in when they went back to being supine again. But being skilled, being able to do them with them sat up with equipment around was something that we found was quite good, that we've got that practice in to do that. When you look at all our lines, we found that midlines were suitable for over half of the patients that we were putting in. The wards were really grateful that we could do the sampling from that. And again, we found not just through COVID, but in the past as well, having a line just avoids those missed treatments where the venflon falls out, that the cannula falls out. It takes a couple of goes to site that cannula. It doesn't last for the length of the treatment. There's a delay. And having that midline just allowed patients to have all that treatment all the way through. In terms of PICs, I want to touch on that because I know the other speakers are talking on that. There was a few patients where they were deteriorating and heading towards intensive care, and those were the ones that we would put a PIC in, so they had that available for vasopressors. There was one or two lines where we were converting them from a midline to a PIC, so we're essentially cannibalizing that midline, rewiring it, and then lining it back up for a PIC line, and that did work very well. And then looking at our overall complication rate, it was exceptionally low throughout this. Essentially, it was blockage and failure that only happened in 2 out of the kind of 151 midlines. So I'm kind of going to finish there. I'd like to say this is the team that work with me. It's a fantastic team. We're really pleased that we've got all these anaesthetic associates that are all skilled and can just take on board everything while we went off to look after intensive care patients. So thank you very much for listening. I'll hand you back to Luke. Thank you.
Well, thank you, Matthew. A very impressive presentation, impressive organization also. And you have the mean length of the time. How long the midline keep on the patient during the hospitalization? What the mean length of the timing of that you keep the midline for the patient?
So we tended to just say, well, we do say that basically the midline will last for the length of the treatment. So if a patient comes in, and we're trying to advocate getting the midline in early. I'm sure you're all aware of patients where they've had 20, 30 attempts at a Benflon, they've failed, and then they come to us to have a midline. And it's like, why didn't you come to us sooner rather than later? And that's the one thing that we're trying to change a lot of at the minute, is trying to get in early. As the patient comes into the hospital, if the ward know they're going to need access for 6 weeks of antibiotics, don't even bother with a Benflon, just come straight to us and we'll put that midline in. So we were finding they were lasting for that whole length of stay. Yeah.
Okay. So Linda, do we have some questions from the audience? And first of all, let me thank the audience, because I know it's a very large audience from all over the world. So welcome to everyone. And maybe Linda, do you have any question or?
Linda's on mute. I think.
Yeah.
Linda, yes.
We have got a couple of questions for Matt. Somebody's asked, in your opinion, what was the greatest difficulty that you encountered when you were adapted to the new COVID situation from a vascular access point of view?
I think basically the biggest difficulty was just having the knowledge of what the gear. Like most people, there was a lot of mixed advice around what PPE to wear. And going to the wards, lots of wards were doing things slightly differently, and we just made a decision that we would do the same thing that we're doing within theatre. And so we were just wearing the full PPE for those suspected and those for kind of like confirmed cases as well. But yeah, that was quite frustrating, just knowing exactly what to wear at what point. Little things like going into the room with the minimal kit, and then if you find that you needed something else, it was hard to communicate that to the outside. So we found that we always, as things progressed, we would have somebody just stood outside the door ready to pass us something if we've got things in. But as time got on, that seemed to settle things down.
Somebody's asked a question about thrombosis rates. I know you've already mentioned catheter to vein ratio, but they've just asked if you had what was your thrombosis rate? So
that we didn't see an increase in thrombosis rate. Our thrombosis rate is relatively small anyway. We do have 1 or 2. In fact, I saw a gentleman this morning. I went to put a line in this morning. We saw a gentleman this morning. There is some thought about kind of the CPAP HUDs with the straps that go under the arms that are decreasing the blood flow in the arms. We didn't tend to see anything. There was definitely no increase in thrombosis rates with those. It was obviously thought about, but we didn't see any increased thrombosis rate, no. I mean, a lot of our patients went onto a COVID pathway, not just for the lines, which included thromboprophylaxis anyway, so they were having low molecular weight heparin injections. So whether or not that skewed the data because they wouldn't ordinarily have had the low molecular weight heparin, I don't know.
I might ask just one more question before we go on to the next presentation, and we'll pick up some more in the general discussion. But somebody's asking what type of midlines did you use, what length midlines, and whether you use dual lumen midlines at all. So
that's a good question. So we use exclusively the Vigon midlines just because they're exactly the same as the PICC lines, and we wanted a standard across the trust that we use. So our midlines are the Vigon, and we tend to use exclusively dual lumen. I know there's a debate about why using 2 lumens versus 1, but we just always seem to use the 2 lumen ones. Yeah, and they've been fantastic. They do work well.
There's more questions, but I can pick those up later if you.
Excellent.
Yeah. Carry on with it.
Yeah, thank you very much, Matt. So we have time maybe later after the free presentation for more discussion. If there are more questions, and certainly we're going to have more questions for you, by the way. So let's start to the second presentation and the second speaker. And the second speaker, everyone knows him, is Mauro Pittirotti. So Mauro is a very well-known surgeon working in the Catholic University Hospital in Rome, Italy. So Mauro lives in Rome, and where he works as a surgeon since 1979. He's one of the best known, of course, world experts in the field of venous access. So he's the founder and the president of the Italian group of central venous access, the Gavelcelt. and collaborates with VOCOVA, the World Conference on Vascular Access, as a chairman and the scientific committee. He's the coordinator of a multi-professional vascular access team that insert more than 7,000 central venous access devices per year, which is increasing. In a career spanning more than 40 years, Mauro has been at the forefront of advance in venous access. He's the co-founder of Italian Society of Parenteral and Enteral Nutrition, the SINPE of the Italian Long-Term Vascular Access Group, and the VOCOVA Foundation, of course. He's also an author, more than 100 papers, several book chapters, and 2 books on venous access, especially. So, and the last but not the least, he received the HELPS Awards of Excellence in Vascular Access in 2009. So, Mauro, I give you the time, 15 minutes, if you agree, for your presentation about PICs and how we can use them. Thank you, Mauro.
Thank you very much for your presentation, Luc. I will try to get my share. Okay. Can you see my presentation now? Can you see it?
Yes.
Okay.
Yes.
Okay.
It's good.
Okay, I'm going to talk about what kind of central venous access we need in patients with COVID in our experience. Basically, a lot of things have changed. As Matt has put it very nicely, we had to reorganize completely our vascular access team, and with some specific goals to make the maximal effectiveness out of this maneuver, to reduce the risk of complication to the patient, at the same time to reduce the risk of contamination of the health operator. We have sort of synthesized our experience in 2 papers, which were published on Journal of Vascular Access and on Critical Care very recently. They practically give the same kind of recommendation, which deals with the different issues. One issue, of course, is the peripheral venous access, which Matt had already discussed. And I completely agree. We had the same experience in COVID patient who did not need an intensive care unit. We actually use a lot of midline catheters. Of course, when we talk about midline catheters, we talk as a midline, mid-clavicular in the European meaning, because as you know, in the USA, if you talk about midline, often they talk about a very short 8 centimeters or 10 centimeters of midline that in Europe we call the long peripheral catheters or mini midline. And we had the same very good experience of Matt. The flow was high, there was easy blood withdrawal, especially because we enforced a tip location of the tip of midline by checking with the ultrasound the position of the tip soon before the clavicle, which is a very important point in getting the midline working. But what I want to talk about is the central venous access. There is little to discuss that the patient in intensive care unit, and unfortunately, we had a lot of COVID patient intensive care unit, need a central line. Need a central line because they need drugs which need a central line because they are pH or their osmolarity or because of their capability of doing damage to the endothelium, because they need a multiple lumen route, because they need a hemodynamic monitoring. And also hemodynamic monitoring, this is interesting, is something that can be done, as we will see, both with the PIC and with the central inserted central line and also with femoral lines, as much as the tip location is in the right atrium. At the same time, the technique of central line placement must be as safe as possible, which means that we can't run the risk of doing a pleuropulmonary damage like the pneumothorax in a COVID patient who already have a serious lung distress. The other point with the central line is that the access site must be as clean as possible. as far as possible from respiratory maneuvers of any kind. So that keeping this in mind, I will very rightly see what are the advantages of our options. The options, and this is the walkover recommendation for central line access for acute central lines, are basically the PICC, CICC, FICC. By PICC, I mean the PIC, which are inserted by puncture of veins, deep veins of the arm. By CICC, central inserted central catheter, I mean central lines whose tip is central, of course, but where the approach is in the jugular, innominate, subclavian, and axillary veins of the supraclavicular, infraclavicular area, and the femoral, of course, in a common or superficial femoral. Let's start from this, from the femoral lines. First of all, we always use CT injectable, power injectable, you know what I mean, anyway you call it, polyurethane catheter, which resists to very high pressure, because that will give you also the possibility not only of the CT scan, but also of high flow. The key point with the femoral lines is that we discovered that you should have the access site not at the groin, but at mid-thigh. And this is possible either approaching directly the superficial femoral vein, which is something that is becoming very popular in the literature worldwide. The superficial femoral vein is very good, very big as the basilic vein, or puncturing the common femoral vein at groin, but tunneling. Of course, the advantage of femora is that there is no pleuropulmonary damage or risk, that the insertion maneuver is very distant from the patient's secretions. There's no interference with the non-invasive ventilation, and also the access site is quite easy to manage if it is not at the groin. Please note that the risk of thrombosis and infection is very, very low, as much as central inserted central line if access site is at mid-thigh. So the message is avoid the sex site of the groin. These are 3 examples. The one on the left is a common femoral vein puncture with a tunneling. And of course, we have been using a very long catheter so that we could get to the right atrium. The second example is a superficial femoral vein puncture without tunneling, puncturing directly at mid-thigh. The third example is an image which was very kindly given to me by my friend Matt Ostroff, which is an example of an ICU patient with COVID with the 2 superficial femoral lines. Triple lumen and double lumen one. What about PICs? PICs share some of the advantages of femoral lines, but they have something more. Of course, when I talk about PIC, I talk exclusively about double lumen, triple lumen, power injectable PICs. And of course, they must be inserted according to the very clear good practice of insertion, which means the appropriate caliber of the vein to fit the caliber of the catheter. There is no risk of pleuropulmonary damage, which is very important. And also there is no risk of significant bleeding. Think that most COVID patients are severely anticoagulated, or at least they were in Italy, most of them. So that there is risk of bleeding for a femoral line, for a common femoral puncture, and risk of bleeding for a central inserted central line, but not for a PIC. You can do the insertion also in a sitting patient or in pronated patient while they are pronated. While on the contrary, this is quite difficult, not impossible, but difficult for central inserted central line and femoral lines. There is no interference with the respiratory equipment or the helmet or non-invasive ventilation, and the access site, as much as the femoral, is quite far from the secretion of the patient. Please note that there is a sort of urban legend which says that the risk of a PIC for thrombosis is higher than central line. This is simply false. It is not true. If you look at this meta-analysis, which is very good, very well, because it was done taking into consideration exclusively PIC inserted with good clinical practice, you see that the PIC-related thrombosis is between 2.2 and 2.5%. symptomatic thrombosis. And if you look at this more recent meta-analysis, which also very well done, is the risk of a peak rate of thrombosis 2.3, while the risk of a central inserted central line is slightly higher, it's a 3.9. So in this meta-analysis, it was also proven that the risk of infection, considering globally all central inserted central line and all peripheral inserted central line, was lower in peak if compared to direct central lines. And these are two examples. We often tunnel the peak. If the vein is too small at the mid part of the arm, we go very close to the axilla and then we tunnel. Tunnel is one of the great things which really makes the decision of the most favorable access site. Last but not least, if you have to use central inserted, the central lines, you can choose either an access site in a supraclavicular area after ultrasound guided puncture of the jugular, or the subclavian, or the brachiocephalic, or in the infraclavicular area after puncture of the axillary vein. Anyway, this is better. To have an access site in the infraclavicular area is definitely better. Definitely better because there is less interference with non-invasive ventilation, etc. Also consider that we can tunnel also the central and central line. But the message is, do not use the neck as an access site. This is something that we have been doing in intensive care unit patient from since many years now, and that it has become particularly important in a COVID patient. These are three examples of central and central line. The one on the left is non-tunneled. The one in the middle is a tunnel because the access site was, the puncture site was in the supraclavicular area, so we decided to tunnel to the infraclavicular area. And the third example is a very extreme example of tunneling. It was a patient in which, because of the pacemaker, we did not like to have the access site in the infraclavicular area, so we tunneled to the arm. So this looks like a peak, but it's a central inserted central line. Of course, anytime you do insertion, whatever it is, peripheral inserted line or central inserted or femoral, the message is do not use do not use X-ray, use all ultrasound, always and ever. Ultrasound guidance is the must for any central line. It was the must before COVID. There are even more good reasons to use ultrasound always with the COVID patient. And the same is for radiology. In our center, we have abandoned radiology since a decade now. We do not use fluoroscopy. We do use post-procedural chest X-ray only in exceptional cases. And this has become particularly important with COVID patients. To use radiology for central venous access is a waste of time, is a waste of resources, is less safe, is less accurate than EKG, but most of it all, there is more risk of contamination of the operator for the COVID patient. We use ultrasound, and particularly we use wireless ultrasound, which were the very important, game changer for COVID patient. To have a wireless ultrasound probe like this, which can be completely cleaned after the maneuver. And you can use ultrasound for really every stat. We are currently using this wireless probe, which we can use for venipuncture, for peripheral lines, for central and central lines, for femoral lines. Of course, we use the linear probe. But you can also use the linear probe for a rule-out pneumothorax. There is no need of doing chest X-ray for excluding pneumothorax. Pneumothorax can be more accurately excluded by ultrasound of the pleural scan or the pleural space. Also, tip navigation can be done very easily with a lot of accuracy and in a completely inexpensive way with the ultrasound. There is no need of using fluoroscopy or using very expensive and unreliable electromagnetic tip navigation systems. Finally, when you revert the probe, you use the convex and the sector for the tip location by a subscriptoid scan or an apical scan. Of course, if you want a very accurate tip location, the best is the intracavitary EKG. Finally, you have to secure and protect the catheter. So the last message is that the motto, secure and protect. You don't want to lose a catheter because of dislodgement in a COVID patient, because that will be it will be extremely embarrassing to go back to the patient, do the same maneuver. And the only way to get zero dislodgement is to use a subcutaneously anchored securement. Even if you use stitches, they will be not as reliable as subcutaneously anchored securement that has been implemented in our hospital now in practically all children, all neonates, and practically in all patients with severe risk of dislodgement, and in particularly in all COVID patients. Finally, last but not least, a very good way to protect the access site is the chanocolate glue, which was always used in COVID patients. COVID patients are on anticoagulants. The risk of local bleeding at the site is big. And the only way to prevent 100% risk of local bleeding is to use chanocolate glue. So you see that the strategy is to get the ideal access site as far as possible from the circulations, which might be the mid-arm or the mid-thigh, to have the ideal securement and the ideal protection too of the access site. And last but not least, of course, you have to protect the operator, not only protect the patient with maximal degree of precaution, but also to protect the operator. Always use a phase filter P2 or P3, 995, 1999 underneath the surgical mask, and remember proper eyes protection. The appropriate cleanings of the material becomes very easy if you're using keyboardless devices, and especially if you use wireless probes like this, which can be completely cleaned. What has changed? Well, we are already in our team, we are already on the right track, so to speak, because we are all already using ultrasound, already using wireless, already using the EKG and the tip location with ultrasound rather than radiology. But all these things that were apparently interesting or effective or important became more and more important in the moment of COVID. So what we are doing now is that we will implement these strategies to be able to consider any type of central lines, peak, femoral, central line before choosing the right line for the right patient. Second, to abandon the routine use of radiology, which is absolutely a waste of time and resources. And to adopt those strategies which make us able to secure the catheter and protect the access site. And thank you very much for this opportunity of speaking this webinar. Thank you, Luke, for your very nice presentation. And thank you, Linda, too.
Thank you, Mauro. Thank you very much. It's always clear. And I know it's very important that such a professional like you upgrade the possibility and the teaching of using ultrasound guidance. It's in my own sense, is very important. And maybe the message is that ultrasound guidance for punctions, and as you say, ultrasound guidance for navigation, and ISO some question, and maybe for tip location. But we need to upgrade the formation and the teaching for that, because not a lot of operators all over the world knows how to do that. And maybe we could share the discussion after the last presentation, because we are quite a little bit late now. And we keep some time after the third presentation to discuss maybe about that, because I see on the on the line. Many questions, and Linda will ask us the question after maybe. So if you agree, we keep the question for after the presentation, Mauro, and we'll discuss all together with Matt and with the audience about that. I think it's the point. Security and safety is the clear point of the vascular access now in COVID and post-COVID situation. Very important. So if you please, I'm going to present myself, but not like the other. I'm Luc Rottenberg. I'm living in Paris, in France, and I'm not an anesthesiologist. I'm not a surgeon. I'm a radiologist, so it's a very large population today. I'm an interventional radiologist, working in west of Paris, in two towns which called Neuilly-sur-Seine and Levallois. Since 25 years, I run a radiology group which is called Radiologie Paris West, reference imaging center in 10 different locations, including the Henry Hartmann Breast Institute, which is a breast cancer institute in Paris, a private one. And also I'm running the Franco-Britannic Hospital of Paris. And I'm a member of the G5, which is the French interdisciplinary group of vascular access. And I know our president, Christian Dupont, maybe is in the audience. So I give him a little hello to Christian. And now let me share my presentation if I can do that. Let me check. Okay, screen. This. Sorry. Yes. Do you see the presentation? Oops. Do you have the presentation on the image? It's okay? Okay. Is it okay?
No.
I see a blank.
Oops, sorry. Is it okay right now?
No.
Just stop
No.
sharing.
Stop sharing. Okay.
So,
And let me share again. Is that a good one?
yes. Now I see it.
Okay. So let's start. So after everything, yes, you see it's okay. So after speaking about ICU situation with Medline and PICS and central lines, let's maybe talk about chest support in cancer situation during COVID and non-COVID, because nothing was stopped, and we try to go on and to continue our practice for cancer patient, especially in emergency. Oops, sorry, it's not working. Sorry. So major change during COVID situation, we have a lockdown in France, as in many countries. And in this lockdown, we have to stop all our patients, all surgery was delayed, and we just have to organize a cancer care COVID-free center dedicated. So we do make a sanctuary with our Hartmann Breast Institute, and the British hospital for us was a COVID positive patient center completely dedicated to COVID, and we try to keep the Hartmann Cancer Center as a sanctuary for COVID. So we do accept patients just for cancer in emergency, in advanced case, in order to avoid lack of chance, of course, for the patient. So we have some challenge faced to this situation. So we have to secure the clinical pathway for the patients. So as we try to keep Hartmann Clinic as a COVID-free sanctuary, but at the beginning, we'd start to do that. After quite more difficult, and we had to secure the department, the operating room, securing security for the patient, and of course for doctor team. This is quite of the suit that we was wearing in the theater rooms. And we try also to have less hospitalization for the patient, and when it was needed, we try to have ambulatory hospitalization or external way with less general anesthesia. So the needs of more interventional radiology, especially in cancer situation, was very important. And as was saying Mauro, we had to add no or less complication for the intervention that we have to do. So the needs created was the specific appointment. The preoperative consultation was at that time a teleconsultation. So in order not to come the patient in the hospital before the intervention, for the anesthetist and for the surgeon also. And of course, the barrier measure and social distanciation was something very difficult. We had to reduce the number of patients in the program with extended session time. And of course, we tried to have more external and ambulatory system. And for the port access, as say more for the peak and for the lines, was the same for us. We wanted to be the farthest from the neck as possible. So the neck approach, as the jugular approach, was completely avoided in our practice at that time, and to keep some easy access for the nurse, because some patient had cancer at COVID and had COVID, sorry, had COVID also. So we had to be very careful with that. So we tried to approach far from the neck. And we never forget that the port insertion have some mechanical complications. So every complication that you can imagine could happen. So I don't list this one, you know, everybody knows the complication. So our duty was to decrease dramatically the risk of those complications. And to decrease those complications was to improve the US guidance procedure. Even for surgeon that was not using before COVID system, before the COVID situation, that was not used the ultrasound guidance, we tried to move their practice, or if they didn't know that, we was making the intervention instead of them. So we use US guidance procedure only for port insertion, only US guidance procedure at that time. And the productivity was adapted to the new distanciation and of course of the secure pathway. So, and more intervention procedures. So the very important thing is the ballistic preoperative consultation, which is presential or in teleconsultation. You have to study the study, the interrogatory for the patient. Of course, to get at that time the ballistic and surgical approach, you have to program your approach to know exactly what to do for each patient, what kind of line, what kind of port, what kind of approach you need regarding the disease that you want to treat, etc., and to target everything. And of course, at that time, you have to explain to the patient the intervention, complication, etc. And in France, like everywhere in the world, you need to get the written informed consent. We are speaking about cancer patients, not in ICU patients. And at that time, since the COVID situation, for all patients, we ask for a COVID-19 testing PCR or serology now in order to know the situation of COVID patient. If they are positive in PCR testing, we delay the intervention, which should be dangerous for the patient. So don't forget the key points that you will have to do in the intervention. What will be the installation of the patient? What will be the surgical approach? What kind of intervention in order to reducing the time and the complication of the patient? And of course, you will need and you will get some US guidance functions. So the surgical approach is very important regarding the disease, the healthy side, to prevent the disease area. And I I show you some ENT disease because in COVID situation, for me, it's a little bit like ENT situation cancer. You have to be far from the neck at that time in order to have secure insertion and secure ports positioning of the patient. So we had three approach principle. The first approach for us was the subclavian approach because in our practice is the easier to do, the fastest and the more convenient for the patient. When not possible or when in special situation when patient asking for brachial access, of course we can do that. But we prefer the subclavian. We can discuss about that. Every team have his own desire on that side. And when it was not possible on subclavian or brachial, we was choosing a femoral way, and never an internal jugular access was avoided in that situation. So why US guided is so important? I say motto, it's important for PIC, it's important for medlines, of course, and it's very important for ports because it reduces the time of the intervention and it reduces dramatically the complication that we saw. So there is a lot of papers about that. You have a big literature about the fact that ultrasound guidance is very effectiveness, and its effectiveness whatever the approach. And just this paper to show you that between jugular and subclavian access, when you use US guidance, ultrasound guidance, there is no difference in the complication and in the procedure between jugular access. So subclavian is a very safe approach when you use ultrasound guidance and not the landmarks. You can use every kind of US ultrasound device. You can use, if you are a radiologist like us and you have a big device in the operating room, you can use it. But if not, as shown already Mauro, you can use wireless devices, small devices dedicated. Every device is okay for the vascular access at the time that you have a good probe, a good lens, the nice frequency, high frequency probes, and a good visualization till to 7 to 10 centimeters in order to see very well your subclavian vein and subclavian vessels also. So before you try to check before starting the intervention, check your endpoint venous access, all the local structures, especially in subclavian, the subclavian artery, the clavicle, and of course the pleura. As Mauro, we see very well the pleura with ultrasound, so we have to teach, you have to learn that, but you see the pleura very well with ultrasound. So when there is a pneumothorax, you see it directly, of course, and you have to check all that. Very easy with this kind of devices, but all devices are very good to see vessels, the arteries there, and the vein, the subclavian vein here, that is very well compressed. That's very easy to make the difference between an artery and a vein and to target it. So whatever the approach, the anesthesia is very important. Every team has its own anesthetic pathway. You can use sedation, just local anesthesia, maybe both, but the intervention have to be not painful at all. That's all that you have to do for the patient at that time. So as I already tell you, we had three preferred approaches, three preferred venous access distant from the neck at the time of COVID and maybe after the time of COVID, because we use for many years in our department the subclavian vein access and basilic and Breton femoral. And let me show just in short small techniques, and we should talk about that. Of course, the subclavian access, as I already told you, is very safe when you use the ultrasound guidance technique approach. There is no more complication, there is less complication. Of course, less complication than when you use the blind puncture, which is quite dangerous. So do it just with ultrasound guidance. And it's very easy at that time. And since 2007, as you see, maybe we perform more than 10,000 procedures with that techniques, and which is very interesting. No pneumothorax, no arterial perfusion, no pinch-off syndrome. It's not 1 or 2, it's quite 0 because it's very easy to avoid those mechanical complications with that technique. Another thing, you can avoid also the tunnelization with this technique. You will access the vein directly by the pocket and by the hole that you made for the ports, and you can access directly to the subclavian vein, as you see here. Oops. So that's the situation. You can see directly the vein here, and I puncture under ultrasound guidance directly. It's very easy. It takes just a few seconds. It's a real-time procedure. And you see the needle advancing, and you push the anterior wall of the vein. And at that time, you can insert the vein and not cross the vein entirely. You put the tip of the needle inside the vein, as I see that, and you don't cross, you never touch the pleura. The artery is quite far. And if you puncture the vein 2 to 4 centimeters up of the costovertebral joint, you never get pinch-off syndrome at that time. So it's quite easy. So as we are radiologists, I'm sorry, Mauro, we do have a fluoroscopy in the theater room, so we use it as radiologists. It's going fast, but I agree with you, when you don't have the fluoroscopy inside your operating room, you don't need it for all patients. And but as we have it, we use it because it takes very few seconds to ensure the positioning, the tip positioning. And after that, you continue the intervention as you always do for all your patients. Always ensure the good blood, the blood return of the intervention. The basilic and brachial, we use it for the PIC, as you, of course, and we can use it for ports. In our department, it's quite less used than less used for ports because there is a little more thrombosis because of the length of the catheter, but it's a teeny. The caliber of the vein, of course, is smaller, and but it's very interesting if the patient doesn't want no scare at all in the chest, and you can perform it. It's like for the PIC, use first the basilic vein if you have the choice. If the basilic is too small, you can use the brachial. And the third choice is the cephalic, but try to use always the inner part of the vein, basilic or brachial vein, which is the best. So exactly the same technique, just to show you, it's an outplug technique puncture. You can puncture it like exactly that the subclavian vein. You can see here anesthetic time. We can advance a little bit more, and yes, as the basilic or the brachial vein is quite smaller, but the technique is always the same. You push on the anterior wall of the vein, which is very compressive and elastic, and up with a small movement, you get the tip of the needle inside the vein. You don't cross it. You are sure you are inside. You don't have to. You don't wait for the blood return. You are sure you are inside, and then you can insert your wire, etc. But the technique is quite exactly the same. And the pocket is the same. You can put the pocket just up the elbow, which is more comfortable for the patient. When the two chest ports are not possible, there is no way because of cardiac situation, because of intervention, because of the disease, you don't have subclavian or brachial access. Okay, you can go to the femoral vein access, which is fair also. The technique is the same. At that time, you use a tunnelization, of course, like the jugular vein. Smaller, yes, the risk of infection is quite a little bigger, but if you do it right, it's okay. The catheter length is quite longer, and it's a little bit less comfortable for the patient. But if you don't have any choice, it's a very good access for the patient. And the femoral vein is quite big. At that time, you see the artery. This is the saphen there that you see with the Mickey ears, and the face of the Mickey is the vein inside, and the technique is always the same. You push the anterior wall, you don't cross it, and you are inside. And the technique is quite, you can see here the wire in the vein, very easy to follow, very easy to navigate with ultrasound in the body, in the inferior vena cava. It's very well seen with ultrasound. You can also use, if you have it in the operating room, your fluoroscopy, but don't wait for it. Of course, you don't waste time with that. It's keep time, it's not wasting. So if you don't have it in the operating room, you don't wait for that. Of course, you can follow with ultrasound and ECG if you don't have that. And the technique is quite the same with tunnelization, and the punction is just under here, under the inguinal part for the vein. That's the best way to punction it, and your pocket will be just in front of the iliac bone, which is the best way for the nurses and quite a little bit more comfortable for the patient. And of course, you ensure the blood return, and the technique is the same, and the situation the same. We also use biological glue instead of the strip. Has Mauro, it's more comfortable, waterproof, and more efficient to decrease the risk of infection of your part. Just to go on, the correct positioning of the distal tip of the catheter is a very big deal after the punction. So take care about that. You can use, instead of say Mauro, you can use, if you have it, the fluoroscopy in the theater room, but don't waste time. I agree with that. But in radio, that's the good positioning under the right bronchus, just in front of the right atrium. The correct positioning is very important because malposition of your catheter leads to severe complication. So if it's too short, the major complication is the thrombosis, and the higher you leave your tip, the higher is the risk of thrombosis. You see in the good position, the risk of thrombosis is 1 to 6%. If you leave it in the subclavian or just up the superior vena cava, the risk is quite half of the patient. So it's very important to insert and to ensure the tip positioning. If it's too low, if it's too long in the heart, the risk is the heart failure. So it's very important. So as I already told, if you have it in your operating room, if you are agree to use it, you can use intraoperative fluoroscopy, but of course it's expensive, of course, inaccuracy for landmarks, because for the landmarks, ultrasound guidance is the only things that you have to do, and it's accurate for navigation and direction, especially in radiologists we use to navigate under fluoroscopy. But if you don't have it, ECG technique for tip positioning is very fair. You have to follow with your catheter, the positioning, waiting for the maximum high of the P wave, and it's very easy to get it. Many devices can help you, and some devices like the Vigon one give you the value of your P wave in the middle of the screen. So it's very easy to see if the P wave is at the maximum or not. And if you go back and down, and you are waiting for the maximum rate of your P wave, and it's very easy. So ECG method for the tip positioning is easy, is feasible in the vast majority of the patient, high accuracy, and non-invasive, repeatable, and reproductive. It's a cheaper, of course, easy to use, easy to learn. You can use it whatever you'd never used it before. It's very easy. So tip location, yes, still remains some controversies about that, but I think it's a question of learning, of teaching, and the habitus of the different differences. One thing we can speak about, it's the plain chest X-ray after and before the first chemotherapy in cancer situation, of course, not in ICU, but sometime in France, we are duty to do that, to ensure the port position and to get a reference image in case of malpositioning after, if it's moved after or something like that, but never in emergency, not waste time. It should not delay the treatment, and maybe delay it for the next day or 2 days after, or just before the first chemotherapy if it's not done in the same day or 1 week after. Last thing, yes, you can use also some ports with markings that allow better visibility. You have many devices that give you a mark, like the C-side, and the C-side give you also the gradation of the flow that you can flow in the device, 1 millimeter per second, 3 or 5, you have different kind. So it's very interesting for radiology, for CT scan, for MRI, to know which kind of port that you have. And it's very easy to insert, and you can check at the same time if the port is in good position, and if you have a flip, if the port is flipped, if you have a flip-flap, it's very easy just with Scopy to ensure that the port is flipped, because the markage is reversed, and it's very easy to know and to say to the nurses, your port is flipped, and don't go to this. So the good results is also the small scale, even in COVID situation for cancer patient, and we use biological glue. So after containment, so the situation is still the same for us. We have to use more guidance procedure, ultrasound guidance procedure. We have to adapt our productivity, because we have to keep the distanciation and the secure pathway for all our patients till now. And we have to communicate. We have to communicate and teach. That's what we are doing now. We are very, very pleased to do that. Try to communicate the challenge of the US guidance procedures and the US guidance navigation, and maybe tip location. So if you have some take-home message, you have to secure the pathway. So we do, and I think all operators do that now. All patients have to get COVID testing before intervention, PCR or serology. You have to reduce your surgical time, reduce complication, and adapt the approach of the patient. And for that, the preoperative consultation, using of ultrasound puncture guidance, your technique of positioning of the port and technique of the tip positioning, and of course the management and complication. We don't have time to speak about that today, but should be speaking for another one, are very important. And in our department, we choose for the first choice is the subclavian vein punction approach, with the small and oblique scare in the deltopectoral groove, with a direct punction without channelization. As we have it, we use the intraoperative fluoroscopy, but we use also the ECG tip location, and we use the biological glue. And of course, one again, communication and teaching are very important in order to improve the level of all the operators all over the world, student, fellow, and we have to discuss with that with all the oncologists and all the operators, whatever the specialties we are making. And it's very important, I think. So thank you very much. I think it was my last slide, and maybe we can go on to the discussion. So, Linda, we leave you we leave your speech. Yeah. So do you have any question? Do you have what you say?
Yeah, there's been a lot of questions. So a lot of questions generated from the 3 really good talks. There's some that have been for Matt, so I'll carry on a couple with Matt, and then I'll go on to the others. So there's a few questions about midlines and about blood sampling from midlines and what your experiences of that.
So initially they work absolutely fine for blood sampling. What we tend to find is that as the time goes on, they tend to be less efficient to get blood out of them. I say this all the time, and the best people to care for lines are the patients themselves. So we have a really good outpatient therapy service, which teaches them to care for their own lines, give them their own agents. And we tend to find that those lines, you'll always be able to get blood back from them. The patients tend to be meticulous at flushing them, keeping them clean. And we only ever tend to see problems when patients come into hospital. If they are flushed correctly with a pulsatile flush and a positive clamp before removing the syringe, then we tend to find you can always get blood back from them. But it is relatively variable what we tend to see. I'd say of the ones that stay in for longer than about 8 weeks, you probably get about 20% that you'll be able to get blood back from those.
Can I comment on this?
Yeah.
Yeah.
I think one of the main points is where the tip is. If you have a tip in a brachial, in a vein of the arm, of course, the efficiency of blood withdrawal will be very low. On the contrary, we are now implementing the ultrasound-based tip location of midline, which means that we check during the maneuver that the tip is in the bigger part of the axillary vein soon before the transition to subclavian, before the clavicular bridge, the strict between clavicle and first rib. If you are very careful in where the tip is, the midline ability of drawing blood will last more. But there is always a time factor, as Matt wisely said, because after a while, there is the fibroblastic sleeve, which covers the midline, so that it's very difficult that after 6 or 7 or 8 weeks, you still have a midline properly working for that. But anyway, there are exceptions, of course.
Yeah, I completely agree. The longest patient we've got has had a midline in for 15 months, and it's still working really well. That is an exception, though. We do, yeah.
Thank you very much. There was a few questions. Just I thought I'd pick this one out. Somebody's asking why anaesthetists, why not nurses in certain lines, and just a sort of bigger discussion maybe about how to go about setting up services.
We are the team that we have. The Vascular Access team is mostly anaesthetic led. We do have a massive proportion of nurses that do put them in those. So in that dedicated PIC room, that's solely led by nurses. There's 2 advanced nurse practitioners. And throughout the hospital, in each CSU, so each clinical specialist unit, there are advanced nurse practitioner nurses that we have trained up to put PIC lines and midlines in. They tend to come and join us for a little bit of time. We tend to, it's usually around about 6 weeks, 4 to 6 weeks to get them trained up to do the midlines and the PIC lines, and then they go back out to their CSU to do them. The training is pretty variable. You can pick up a midline very, very quickly. If they're dedicated and they're good to do it, you can learn to do that very quickly indeed. Say a week, 2 weeks, something like that. The PIC lines and the complications is what people have to learn to deal with, as with anything. And the more you do, the more complications and little tricks you might try and learn. So we do have quite a lot of nurses. We have a lot of AMPs that go around and stay within the CSUs to put them in. And a lot of them are based within intensive care. So we do have some nurses on intensive care that will put their own PIC lines in.
Well, I think this is a false problem. The problem is that you want a maneuver performed by a personnel, a staff which is specifically and properly trained. I don't give a damn if they are nurses, anesthesiologists, doctors, or whatever. We do training courses for ports, for PIC ports, for PIC, and absolutely I'm not interested in knowing where I'm teaching to a nurse or a doctor. The important thing is that at the very end, in our hospital, each port, for instance, or PIC is inserted by something which is certified by the hospital to be able to insert a port or a PIC or whatever. For instance, we insert something like 2,000 ports and 95% of them are inserted by nurses. But they are professionals who are specifically probably trained. So I don't want to hear about that because it makes me angry. The fact that you're a nurse does not make you more efficient in inserting a PIC. The fact that you're an anesthesiologist does not make you more effective or performing in inserting a central line. The fact that you're a radiologist, that must make you more efficient in a port, etc., etc., etc. The core of the question is the technique, the how, and how well is the personnel trained.
Yeah,
Yes,
I echo that. Also, it's having the motivation, and if people want to do it and they're keen to learn, they will pick it up very quickly.
Absolutely. The motivation may be very different from, depending whether you are a nurse or a physician or whatever. But very good point.
Thank you very much for that. I don't got very much time left. There was a question which probably Mauro, Luke can mention. You both mentioned femoral lines. Somebody's asked a question about femoral lines and the increased risk of thrombosis, particularly in COVID patients, because we know that they have issues with the thrombosis.
This did not happen, but did not happen because the key point is where the line comes out. You know that the groin is a very movable area where the catheter is unstable. If that will increase the risk of thrombosis. On the contrary, if you're a mid-thigh, the risk of thrombosis is low. Exactly what happened many years ago with PICs. The PICs at the elbow were in a very movable area, flexion area, and there was a high risk of thrombosis. Yeah. On the contrary, now that we insert a PIC here, the risk of thrombosis goes down. The second factor, of course, is the diameter of the vein. If the diameter of the vein is not appropriate, of course, we don't do the superficial femoral, we do the common femoral, but we tunnel so that the catheter will be stable. Anyway, if you look at the international literature, there is no evidence that if you select properly the access site, and if you select properly the catheter to vein ratio, there is increased risk of femoral thrombosis rather than from other sites. And the same is for infection. Infection is basically due to the fact that when you think about femoral, you think about the groin access site, which should be avoided.
Yeah, I'm agree with you. I'm agree with you, Mauro. So in all femoral access we made, there is no more thrombosis on the access point, because as I show you, we access to the femoral common vein, not the superficial, which is very big and the diameter is very large. So, and it's very easy to puncture under ultrasound guidance. And of course, as you say, as I show you, we make a tunnelization, which is quite longer because you place your ports just in front of the iliac bone, which is the more efficient for nurses and comfortable for patients. So we don't have a little bit more, but okay, I think it's a common thinking about that it should be more infected, etc., etc. And okay, for us, it takes a little bit more because we are making utilization, and as when we perform the subclavian access, so it's so fast and quick that it's so easy for us. And I'm right with both of you about it was my last slide. Whatever your specialty, whatever you are a doctor, whatever you are a nurse, if you do it well, if you do it right, it's not important who you are. What is important is that you do it well, and and get well formation, good formation, and very specialized and dedicated to that.
I completely agree. Though when you talk about subclavian, Luke, I hate to say this, but I have to say this.
Say
when you talk about subclavian, most of the time you're talking really about the axillary vein. Because if we want to be very, very picky, the transition between an axillary vein and subclavian vein is the lateral border of the first rib, which usually you can't see most of the time. So you say subclavian access for a matter of simplicity.
Exactly.
But as a matter of fact, sometimes we puncture most of the time we puncture the axillary vein. So I think we agree with that, but just the problem of naming the vein. We are talking about exactly the same thing, which is the new thing here in the ultrasound guided central access. to puncture the vein in the infraclavicular area by ultrasound, which is incredibly better than jugular.
Yeah. Yes, I'm right. And we call it as we want. What is very important is to puncture it 2 to 4 centimeters in front of the joint, because if you are too close from the joint, the risk of Pynchon syndrome is very high. So if you are 2 centimeters below, there is no joint. After that, you have the choice regarding the anatomy of the patient, should be subclavian or axillary. It doesn't matter. You call it how we want, because this area is very easy and very fair to function and very secure for the patient.
I think we've got time just for one more question, but we will pick up on all the questions that were asked and answer them and share the answers with everybody. So this last question is just about brachial ports, and somebody's asking about advice about obstruction. They seem to think that that might be a complication or an issue with brachial ports. Any comments or advice about that? Well,
we do more brachial ports than axillary ports. As a matter of fact, at present, we do 50% of 2,000 per year. Approximately 50% is brachial, 45% is axillary, and maybe 5% maybe innominate vein or supraclavicular subclavian approach, and no jugular practically, and very little femoral. So I think that our experience in PICC ports is quite big. Also, there are other 5 or 6 centers in Italy which do a lot of PICC ports. And I can tell you that if we talk about PICC ports, which means ports, brachial ports inserted by the ultrasound with the EKG technique, with a microintroducer kit, which practically is the state-of-the-art technique of PICC insertion. If this is definition of PICC ports, then the risk of thrombosis, infection, malfunction, etc., is exactly the same as chest port. I think that we still rely on the old literature of the 20th century, where the brachial ports were ports inserted blindly in the antecubital vein and with the strange flexure of the catheter, with the catheter here in the forearm, with a reservoir in the forearm, etc. Now that we have moved the technical knowledge of PICCs and microintroducer kits, ultrasound, EKG, etc., we have moved to PICC ports. And in this interpretation, PICC ports are exactly as safe as a thoracic port. We basically choose a chest port and PICC ports looking at the preference of the patient. And in our unit, most female patients, for instance, really prefer PICC ports.
Okay, that's lovely. Somebody's asked about certificates. We're hopefully going to get certificates of attendance for everybody who has participated in the webinar today. Have we got time for one more question? I think we might I can fit in one more. There's about ECG versus ECG tip ligation versus chest x-rays. Just your thoughts on that.
Yeah. There are at least 3 great papers done between the 2006 and 2009 from 3 different groups in 3 different parts of the world, Germany, Taiwan, South Korea, which made exactly the same study. They did tip location simultaneously with radiology, EKG, and transesophageal echocardio, which is the top, the most accurate ever, because you actually see where there's the catheter junction, you see the catheter, etc. And all these 3 studies admitted that intracatheter EKG was closer to the results of transesophageal echocardio than radiology. Radiology, as very nicely Luke has admitted, is an interpretation of shadows. The inaccuracy of the landmark or radiological landmark is inevitable. On the contrary, when you do EKG, you actually see where the transition between supravena cava and the atrium is, because you see the electrical transition, which is very faithful, not always applicable, but there are patients which you can't see the P, but if you see the P, this is a very neat and clear point. On the contrary, when you do a radiological landmark, for instance, the bronchus or the carina, etc., we are doing any statistical inference, knowing that most of the time, for instance, the cavitar junction is 3 centimeters below the carina in the adult patient, but it's just a statistical inference, not actually seeing. So that's why I say that intracavitary EKG is more accurate to radiology.
Yeah.
And I'm sorry, but to say you agree, but you say that you use fluoroscopy because you had it.
Exactly.
Look, this is a poor argument.
No, it's not a poor argument, because
you should have what is best for the patient and for the hospital, which means that you should be able to choose the strategy which is most accurate, safest for the patient and for the operator, and least expensive. So if you put these three things together, a mix of EKG and ultrasound is definitely safer, more accurate, and less expensive than radiology.
I think I'd like just to add one little point there as well, Mara. I agree with you. I haven't used fluoroscopy to put a pick in about 3-4 years now. I use the ECG placement. When I did first start to do it, I did them both just to get used to using the ECG. And what I found very quickly after one list was actually using fluoroscopy, you tend to leave the line shorter. I found it very interesting that I'd position it with the fluoroscopy, and then I would look at the ECG and realize that I could go in on much further. So as a general rule, we were leaving them much shorter using fluoroscopy than using EKG. One little point I'd like to make though is most of these lines are put in with the patients lying supine. And what you've got to remember is that as they stand up, mediastinum drops by a couple of centimeters, and also on deep inspiration, mediastinum drops by a couple
Absolutely.
of centimeters.
Very good point. This is for any kind of dislocation method.
Absolutely. So
that's why very often we put a pick in a sitting position.
Yeah.
Because the error would be less.
Yeah.
Anyway, I have a question, a final question for Linda.
Okay.
Linda, do we have any way to answer all the questions in the chat? Because I would hate to leave all these people who made a very interesting question sometimes without an answer. So
no, there've been some great questions, so we'll get together and answer all of the questions, collate them all, and we'll send them out to everybody. So none of the questions will be left unanswered.
If we get
I'm
an answer for the question, yeah, of course.
Yeah.
But just to answer tomorrow, you're right, and we have to move. So when I try to speak, I try to speak to everybody, that all teams all over the world have different kind of dislocation. Of course, we have to move, and that I'm agree with you. And we start to do it for many years now, to move from fluoroscopy to ECG, because we make both. Hazmat, we try with both situation, and we try to see if it was okay. And ECG is a very good, of course, it's very good situation for dislocation. So we have to move the practice, and we have to ensure that the people knows how to use it. And as I said, it's question of communication, it's question of teaching, and we have to try, and we have to go on to teach the young doctors to those techniques that they don't have to choose. And thanks to you, Mauro, with your publication, etc. We know now, because you make a lot, and not only you, but all the lecturer, the people that publishing, of course, the brachial situation, as I show you, if you don't cross the vein, you just go by the anterior wall, there is no hematoma, lower risk of thrombosis, etc. Of course, you're right, but it's a question of moving, and people have to, okay, for now, they use what they have. They know that they have. Not all doctors, not all teams all over the world have UCG dislocation device. So, but we have to move. It's not expensive, but for some people, it's very expensive. So they do have fluoroscopy in their hospital. Of course, they have to move to UCG, but okay, we have to
look, don't move. Don't go in the costs, because a thing like this cost 4,000 or 5,000 euros.
No, maybe less.
Which means that if you are in a small country where there is a critical lack of resources, you may want to invest in ultrasound, which is incredibly expensive and accurate, rather than big fluoroscopy appear, you know? Even the use of fluoroscopy is expensive.
No, you're right. But we have to move.
I think we've come to the end of the webinar. It's been a really interesting discussion. I think I'll leave it to Luke to close the webinar.
Oh, yes, with pleasure, Linda. So no, it was a great pleasure to share this webinar with you, Linda. Wonderful on the screen, and with Matt and Maro, of course. You see, the discussion are always passionate because Matt, Mauro, and I are passionate by the techniques, and we like to share the experience, of course. And we would like that people, maybe if you hear this webinar, maybe try to move your practice. First of all, the ultrasound punction guidance I think it's the first thing to do, because it's very, very important in order to get a very safe situation. And then if you have the opportunity to buy a wireless probe, buy it and do it, because you can do everything with that. I agree with you, Mauro. I'm a radiologist, I'm an echographist, and I know what to say, and I use it also. And so try always to move your practice to try to find the best way for your patient, and especially in COVID situation, in order to decrease the risk of complication, far from the neck, ultrasound guidance, tip location, navigation, everything might be in the good situation for your patient and for the team, for the whole hospital team. So thank you to everyone. Thank you to everybody. Thanks to the speakers, of course. And I hope maybe we should do it again on other subject. Maybe we didn't speak about complication. I saw a lot of questions about complication and about what we do after for the nurses, the flushing, etc. There's many questions that I see. Maybe we should answer them by mail if we get the mail of the audience, and it would be a pleasure to try to answer to you. And maybe next time, and thanks to Vigon Society to make possible this webinar. Thank you to Cyril, thank you to Tiffany, and thanks to you, Linda, for your nice company.
Thank you all as well. Fantastic webinar. Thanks to everybody as well who attended.